Hi, welcome back to JAMA Network Open. I'm Seth Truger, Digital Media Editor for JAMA Network Open.
And I'm Mike Berkowitz, Electronic Editor for JAMA and the JAMA Network, back in my regular seat after a guest appearance by Fred Rivera last week.
Yeah, it was great having him here. Editor-in-Chief of the Journal was in town, so came and showered some wisdom on us, which is always great.
Right. Now, he's a pediatrician. I'm a general internist. He knows more about these papers because he evaluated them, worked with the authors to develop them, but I'll do what I can to stand in his large footprint.
Yeah, I think you do okay.
Thanks.
Yeah. All right, so thanks for joining us again. If you're following along live, please comment on the Facebook post or mention us at JAMA Network Open on Twitter. If you've got questions or comments, we'd love to answer them in real time if you're following along. And I think hopefully some of the authors are joining us today.
Oh, that's great.
We'll
and
see.
If you can't make it live and are watching this after the fact, you can still leave your comments or questions in the comment section or in replies on Twitter, and we'll try and answer them.
And now you can also leave comments on YouTube
We're
as well.
on YouTube, right. I think that was new, and I didn't quite catch up.
Yep, 50% more media platforms are being live streamed now.
Awesome. We're nothing but contemporary.
Right.
So what do we have lined up today?
All right, so we've got three great papers today. First one we have is the association between pre-deployment optimism and onset of post-deployment pain in U.S. Army soldiers by Afton Hassett and colleagues.
So this is interesting. This is very contemporary because we know there's armed services in multiple theaters, and this is about pre-existing optimism in Army soldiers and whether it affects their health perceptions after deployment. Right. So unpack that for us. How are they measuring all those things?
Right. So they took, what was it, 20,000 soldiers who deployed to Afghanistan or Iraq between 2010 and 2014. Before they went out, they gave them basically these big kind of mental health mood surveys. It's from the, I'm going to get it wrong here, the global assessment of something. It was for
global assessment tool adapted from the revised life orientation test.
Right, and they used 4 5-point Likert scales to assess their optimism, and basically, how optimistic are you about the future, that sort of thing. And then later went back and checked and saw, of all the soldiers who didn't have any chronic pain, things like back pain, joint pain, or frequent headaches, did any of them develop these kind of chronic pain syndromes?
Right, so it's any new pain, new back pain, new joint pain, and new frequent headaches. Right. And they did, I think, a basic multivariable analysis with the dependent variable of interest being this optimism rating, adjusting for all intensity of combat exposure and all these other things.
Yeah, all the things were like, obviously, people who had combat injuries would be more likely to have chronic pain if they survived them. So it makes sense to adjust for that, and they did. And what they found was that the soldiers who were more optimistic were less likely to develop chronic pain syndromes.
So that's kind of intuitive. It's a kind of a happy paper in the sense that it's the result that you would expect.
Right.
What I wasn't exactly clear on is, okay, so your soldier recruit is not so optimistic on an initial screen. What does that mean?
Right. Well, I mean, what we can say from this is that means they're more likely to develop pain syndrome, but this was not an intervention. We don't know if, say, training people to be more optimistic will lead to, a decrease in developing pain syndromes down the road, which would be great. This sounds like a great foundational project for an intervention.
Right. The authors say that soldiers with low levels of optimism may benefit from programs geared toward enhancing optimism. So I wasn't quite sure what those programs were, other than Robin Williams movies or The End of Life of Brian, which is, always look on the bright side of life.
Right. Exactly. It's always always a good idea. So again, it's without the intervention, we don't know if, without studying an intervention, we don't know if that makes a difference. And again, it's no surprise that soldiers who are more optimistic are more likely to avoid these kind of things. That being said, it's always good to do science even when we find the answer is not surprising, because we are surprised not uncommonly. And what we think should be the way is not always the way.
And the other thing that struck me about this is that I didn't see whether there were measures of kind of more standard clinical constructs like depression or social relationships. They accounted for marriage or not marriage, but kind of social networks and these other things that may stand in or be aliased or be correlated with optimism. Kind of people being connected to one another and having reasons to be looking forward to things as opposed to not.
Right, and there's another couple other things that are unique about this sample is, is the population of Army soldiers who are, going to go to, combat areas.
Right.
So they're younger and healthier in some ways, but also, facing a much daunter short-term future than most of us do.
Right.
So it's very different than, random people on the street.
Right. But interesting research, and I know this is a body of work that the senior author and I think the primary author have been involved in terms of understanding how to get better outcomes given this prolonged field exposure that these service people have in order to make sure that they come through the experience in the healthiest way possible.
Right, exactly. You know, we all appreciate the service that our service people do. We both worked in VA systems.
Absolutely.
And, you know, the more we can do to, you know, support our service people, get better outcomes from them, deal with less pain, less suffering on the, you know, the long term, that's better for everybody.
I agree.
Yeah.
What do you have next?
All right, next we've got a complicated paper, The Effect of Financial Bonus Size, Loss Aversion, and Increased Social Pressure on Physician Pay for Performance, a randomized clinical trial and cohort study by Amal Navith and colleagues from Penn.
From Penn, right. So some of these are kind of my old colleagues, probably my contemporary colleagues still, although we haven't been in touch in a while. So just to put this in context, Pay for Performance, I don't know how many international viewers we have, Seth, but Pay for Performance is important, at least in the U.S. healthcare system, because it's a proposed idea that we can incentivize people to deliver better healthcare quality. Healthcare, you know, is suffused with money, and the question is, are we getting value for the amount that we're spending? And so this group at Penn and other people in this area of behavioral economics have been interested in understanding whether we can use small financial incentives, maybe not so small in financial incentives, on the, but in any event, use the money that's flowing through the system in order to kind of compel or incentivize the kinds of behaviors and healthcare quality that we would want.
Right, and one of the many things that was part of Obamacare, or the Affordable Care Act, was adding pay for performance and paying for quality into the kind of Medicare system.
Right.
And not unrelated, Zeke Emanuel is the senior author of the study.
Right, and he's a friend of the journal. Right. And in this case, the performance was related to kind of 5 kind of conditions that you would expect: asthma, COPD, type 2 diabetes, coronary artery disease, and heart failures. Right. And one of the things I had to look for that didn't come forward in this paper, that as a kind of a clinician I was interested in knowing, is what these measures were. And they were what you would expect, that you do blood pressure screens, that you do tobacco cessation counseling,
diabetic foot checks.
Diabetic foot checks, beta blockers for heart failure, and so on. So those are the performance measures that we're trying to get clinicians to at least document, if not actually perform.
Right, and I'm not a primary care doc, so I don't deal with this sort of prescribing, but it certainly makes sense that these are chronic conditions that have, you know, best practices, they have international guidelines, they have, you know, what we all think are kind of the care we should be providing, at least at a baseline. So it makes sense if we're, you know, giving out a ton of taxpayer money for this stuff, to have it pegged to some sort of quality payment, if there's a valid measure you can do.
Right, so what were the behavioral economic principles that were put into play in this randomized trial?
Sure, so they did 3 things. The main thing they did was give what they called a large bonus size, which is basically increasing the productivity bonus that these docs were getting by about 10% from the year before. In addition, they tried to do some behavioral economics of loss aversion and increased social pressure.
So that's interesting, because when I read this superficially, I was thinking that the large bonus was itself an intervention, but that's kind of like, that's baseline. It's not tied to, it's tied to productivity, but not necessarily quality and performance, right?
Right, and that's actually one of the things, the main reason why this is an RCT and a cohort study, is because the way they describe it is they didn't feel it was culturally appropriate to randomize people to getting a bonus or not getting a bonus, which is understandable.
That's a sure way to have 100% participant withdrawal from the study. And we should note that this is actually, I think, a cluster randomized trial, in the sense that physicians were randomized, but the unit of analysis is at the patient level.
Right, exactly. Yeah, and it was actually local here in the Chicago area, is the advocate system at the Trinity Hospital and their affiliates.
Okay, so everybody got kind of excess bonus, or at least a generous bonus, on an individual basis. And then what were the other 2 interventions?
So the loss aversion was, they basically put an estimate of what the nest egg of their bonus was going to be. So I think it was 50% of the previous year's bonus, and what they described as a virtual bank account, which they could take the money out, they could basically draw against it. And if they took too much out and didn't earn their bonus for the current year, they'd have to pay it back. So they basically try to give them some money and say, hey, here's your money. If you don't do a good job, we're going to take it from you, to try to harness that loss aversion, which has come out, in my understanding, in the behavioral economics literature as probably the biggest driver in that field.
So I'm going to perform better because I know that there's a nest egg sitting for me that I don't want to lose, right?
Right. And this is basically the foundation of the movie Gung Ho from the 80s with Michael Keaton, was that...
I didn't see that one. I saw Birdman and I saw Batman, but I didn't see that one.
I think it predates Batman. But the idea was there's a blue-collar man.
Beetlejuice, I saw that one too.
That's a good movie. Yeah. And probably my favorite Batman still. But a lot of that probably has to do with when I was in my formative years.
Right.
And I haven't seen the Ben Affleck ones, so we're not going to go there. But anyway, so the whole idea in the movie, which is obviously much less interesting than the paper, is there was I think it was like a upper Midwest typical blue-collar American car plant. A big company took over and said, and lowered salaries and said, all right, we'll give you your salary back. We'll give you a big bonus if you meet this big, outlandish, very ambitious goal of car production. And there was a big conversation among the workers of, what if we try really hard, we get really close, so we don't get it? And basically the whole idea is, is it even worth trying if you may not get the bonus? But the flip side is, what they do here with loss aversion is, if here's your money, take the money, and if you don't do a good job, we're going to take it from you. It's kind of the opposite of a bonus.
Okay. Well, I've read the paper. I haven't seen the movie, so I have some follow-up movie questions, but I'll spare my audience on that. Okay, so that's loss aversion. That's one interventional arm. And is there another interventional arm?
There's one more, and that is increased social pressure, where they basically used, unblinded, showed the docs and their colleagues how everybody else was doing on these performance measures.
Okay. And I think that was in a different proportion than is usually the case. I think under normal pay-for-performance setups, 20% of the bonus or the pay incentive is related to how the group does as opposed to how the individual does. So they dialed that down to 50-50, if I remember correctly, so that everybody was kind of more responsible to everybody else. It's just another way of kind of incentivizing performance through a mild adjustment in these kind of financial arrangements. And it's really psychological, interestingly, rather than actually financial, right?
And the lack of blinding to me was really interesting, because a lot of what I've seen is, and what we do in my department is kind of blinded comparison to peers. How are you doing? How are you prescribing? How many CTs am I ordering? How many people am I admitting? And I see how all my peers are doing, but I don't know who the individuals are. But there's still, I'd say, some level of social pressure where, like, I don't want to be somewhere, I don't want to be an outlier.
You don't want to be the outlier. Right. And as docs, we're typically competitive. That's how we make it through the system, and so that's the case here in these kind of public reporting, blinded or not.
And even if we're not competitive, we have imposter syndrome, and we get worried that we're not as good as our colleagues, and we, it's good to have evidence that we're not following behind.
Right. We all want that positive mirroring. Okay, so in any event, we have this randomized controlled trial, 3 arms. What do we find?
Well, first, most importantly, we're getting some unblinded feedback right now by the first author, Amal Navath, that we are actually described the study properly.
Oh, awesome. Thank you, Amal.
Good.
And thanks, Kevin, if you're watching. Appreciate it.
And hopefully I'm doing a decent job of pronouncing your name, and I apologize if I'm not.
Okay.
So basically what they found in this paper was that the only thing that worked in their study was the large bonus size. So the bonus size worked. The docs who got the bonus did better in achieving the quality metrics, but the loss aversion didn't work and the increased social pressure didn't work.
Okay, and why? What did they? Can you unpack that a little bit?
Sure. So probably the most important thing they found was that their loss aversion probably didn't work because, well, part of it was both the loss aversion and the increased social pressure. They ended up whittling down to a pretty small subsample size, so only about 3 dozen docs were left by that point. Which is, just this is difficult pragmatic science to do, and that happens. Unfortunately, you get down to small cell sizes. Number 2, the loss aversion just didn't really seem to come into play a lot. One is it sounded like they pegged those virtual accounts at a pretty achievable goal. So all you had to do is beat half of what your productivity bonus was the year before, and I think it was 94% of the docs were hitting that anyway, so there wasn't any loss to avert. And it looked like only a handful of docs were actually accessing that virtual money anyway. Which is tough.
And it's really tough. Yeah, I mean, you put your best ideas forward, you kind of spell it out, and then often trials go in their own direction, and they end up being something other than you planned, but it's still evidence. You've still consented people, and so it's great that the authors kind of put this out in the literature for us to kind of figure out what to do. So what are next steps, or what do the authors identify as the kind of the takeaways, if any, and in terms of healthcare reform or behavioral economics and health systems?
Yeah. Well, I mean, I think the number one takeaway is docs do respond in some way to bonuses. Bonuses
money.
are good. We like money.
Yep.
We're realistic about it. Again, I think they were limited by some of the pragmatic aspects of it. And if this bonus was like 50% of their annual salary was on the hook, I think I would not want to be a manager who had to implement that at a practice. Basically,
Right.
That sounds like a pretty scary thing. What else did you find?
So I'm just speculating whether it makes sense, for health systems to. I mean, I think it does. We all know this in businesses. You try and, as an employee, you try and get a high base pay. But as a health system, you might want to offer a low base pay and tantalize people with the prospects of a larger bonus and tie it to performance.
Yep.
Now, that's in a kind of a traditional healthcare system that we're used to. Of course, the Kaisers, the Mayo Clinics, these are all kind of employees, and I guess there's some profit sharing that's going on there. But it may not apply to all systems. Ultimately, healthcare quality, as I understand it, is really tied to not fee-for-service, and people who kind of are all bought into the mission of an organization.
Yep, absolutely. And thank you again for chiming in, but Dr. Nabath is here saying that they're completing a qualitative study now that seems to indicate that social pressure did lead to practice changes, which is good. And they say they're wondering if they had run the study longer, they might have reached significance. So again, limited by small sample sizes, this is hard science to do. It's really difficult to interact with docs who are doing this, to get them to play ball, and then to manipulate it in a way where there's something you can study. So kudos to you guys for getting this done, and I'm looking forward to future work on this.
Right. And let's just not, we've been talking a lot about health systems and about
Right.
money and about doctors. Let's not forget the patients. It's ultimately about delivering better care to patients,
Right.
which is why we're having this conversation and doing this research.
Right. And also, it's easy to be skeptical about a lot of the interventions and a lot of things like pay for performance and how they may or may not be impacting practice or improving patient care. But I think it's also important to remember that the status quo has incentives of its own. So it's not like we're operating in this, in this empty field and we're just starting new things. There are incentives right now in the system, and the question is what incentives could docs potentially respond to better to provide better care?
Right, and there are I would counter that by saying there are disincentives for change, because there's a lot of winners in the current system, and we know healthcare quality can improve. The question is how to get people off their practice dimes, so to speak, to improve efficiencies and decrease waste, improve quality and improve outcomes ultimately, which these quality measures presumably are kind of surrogate measures, beta blockers for heart failure. We know from randomized trial evidence that improves outcomes. The beta blockers themselves are procedure measures, but the idea is to improve health outcomes for populations.
Right, and I just have to ask for clarity, when you say practice time, is that a mashup of paradigm and practice?
No, it was my trying to be poetic and creative and failing.
Okay, no, it's fine, I like portmanteaus.
Okay, yes, good. What do you have next, third and last article?
Okay, next one, shifting gears a bit to a clinical topic, long-term outcomes of endovascular and open repair for traumatic thoracic aortic injury by Yuting Chang and colleagues.
Okay, so I feel a little bit more grounded. This is kind of clinical medicine, traumatic thoracic aortic injury. As a general internist, I don't see much of that. I would see, AAAs in the emergency room. Tell me about this paper and what I need to know.
Right. So if you remember, a few weeks ago, we talked about a paper by Salata and colleagues on AAAs and AAA repairs in Canada. This is different. This is on traumatic thoracic aortic injury. So basically, patient gets into a car accident, their aorta gets torn a bit, and nobody's happy. And the question is, are they doing better if they go for open repair or TVAR, basically invasive approach or interventional approach, excuse me.
An interventional approach, but a minimally invasive approach as opposed to an open approach.
Right. Exactly. So in general, my understanding with TVAR is they basically go in like with a in the cath lab and put in basically a stent graft.
Stent graft. Okay, so I don't know the actual mechanisms of trauma and when that's appropriate and when that's not. I think we may have had this conversation. Who are doing these? Is this interventional radiology? Is this vascular surgery?
Right. So as with many medical questions, the answer is it depends.
Right.
My understanding, my experience is that there's a bunch of different specialties which overlap in this. It's vascular surgery, cardiothoracic surgery, interventional radiology in some institutions, as well as I think I've even heard of interventional cardiologists who do these.
Really?
Yep.
Okay.
Not a lot, but I think in my experience, the institution I've been at, it's been mostly vascular surgeons and then some cardiothoracic surgeons.
Got it. And so this is really, just to be clear for our viewers, surgical epidemiology. This uses a Taiwan national database, which gets like 100% capture of everything that goes on in their healthcare system in a fairly homogeneous population. And out of that, if you'll allow me to just kind of give a little bit of the detail of the study, there were 287 patients who received open repair or thoracic endovascular repair for their traumatic thoracic aortic difficulties. Injury, right.
Yep.
Okay, so this is out of Taiwan, so what we're talking about, who does this, might be very different there.
Right.
And so what do we learn from this report?
So basically two things is not surprisingly, we're moving away from open repair and towards TVAR. So TVAR is becoming much more commonplace,
right.
As we found with the elective AAAs.
That was kind of the same thing that we talked about.
And also finding that outcomes are better with TVAR. So they did propensity match, propensity score matching. They try to compare the patients to each other. It's still a, observational study. It's administrative. It's looking back at big databases. It's hard to know if the patients were exactly the same, and are we selecting sicker patients to go for open repair? It certainly seems to me like there's probably some element of that.
Right.
That sicker patients probably need to be opened up, and you need to be stable enough to have somebody thread a wire up and put in the stent.
Well, it could be otherwise, right? You could be doing the minimally invasive in the patients who are too sick for an open procedure.
Absolutely.
And that's just for people who may not know, who are watching, what propensity score matching is. It's one mechanism that's imperfect, but gets the ball a little bit further down the field for adjusting for differences between two observational groups to the extent that you can using measured variables. So you try and say, what's the propensity that somebody was received open repair or minimally invasive repair based on other kind of clinical characteristics. Right. So it's, I think of it as a multivariable regression within a multivariable regression, because you're trying to kind of figure out what predicts the likelihood or the probability of getting a one type of repair versus another, and then you match people with equal probabilities, and then you look at the outcomes.
Right.
I don't know whether I made that more clear or more confusing, but it's just interesting and a way to use to kind of approach observational data. Other approaches are instrumental variables. I'm sure there are others that I'm forgetting in the moment.
But yeah, it's basically ultimately the way I think about it as a simple ER doc is it's a form of risk adjustment when you're doing observational data.
See, he said it much better than I did and much more clear. So we know we're moving towards minimally invasive procedures. That seems to be happening all over the place because it's quicker healing and maybe equal outcomes. That's what we have to figure out. One of the things I worry about, and when I generically as kind of dislodging plaque but I'm maybe thinking about AAAs with this, and kind of cholesterol and plaque embolisms in this population, but this has nothing to do with that.
No, but this is something they pay attention to because they do report, one of the things they look at is downstream strokes. So are patients having strokes? That's always an outcome in these kind of studies, or it's in the ones I'm familiar with anyway. And only 2 patients out of the 200 or so had a stroke down the line. So that's, at least all these patients aren't dropping dead of strokes, which is good, or dropping paralysis, having paresed by strokes.
Okay, so this is good surgical information. It's a brick in the wall of evidence about these available procedures, and I guess we'll await the next minimally invasive epi study to see how minimally invasive procedures do.
Yeah, and I mean this stuff really makes a lot of sense. Blunt traumatic aortic injuries are bad. You can get some pretty significant injuries from this stuff. These aren't patients who are have a lot of time. These are patients who are generally sick to begin with just from their injury, and they may not have the ability to withstand, as you said, a big open operation, and the healing goes along with that. And as with most things in critical care, a lot of this stuff is doing as little as possible to support our patients so that they can heal, or so we can do what we can to heal them. And if minimally invasive is better for them, then, or if the patients are able to recover better from a minimally invasive procedure that fixes them just enough, then that's plausible that it's better. And I think this is an observational study that, as you said, is one more brick in the wall that supports it.
Fabulous. We got one more comment, I think, from The primary author, the principal author and PI of the prior study, giving us props for covering his study and props to you for conducting it. So mutual love.
Right, and this increased social pressure is keeping us honest.
Right, so I think that's a wrap for today, right?
Yep, that's what we've got. Thank you for joining us. Of course, you can read these and more papers at JNOnetworkopen.com. Everything's open access and free to download. You can get fancy PDFs if you want to download them, put them on your phone. Of course, follow us on Facebook, Twitter, LinkedIn, and YouTube at JAMA Network Open.
Great, and check in at JAMANetworkOpen.com every Friday, 10 a.m., Greenwich Mean Time -6. For our latest releases, because that's when stuff comes out, and then we start to put it out into social over the weekend. It is still snowing here in Chicago, and I expect next week when we're back and the week after, maybe we'll be able to say the same.
Yeah, maybe. Hopefully not. Hopefully some of this will melt, because it's pretty icy out there. So be careful walking around. You don't want to bust up your aorta.
Be careful. Thanks for joining us, and we'll see you next time.
Join us again next week.
Take care.